Hypertrophic cardiomyopathy and splenomegaly, the pathophysiology and etiology. First, hypertrophic cardiomyopathy. Over half of all cases are familial, which is an autosomal dominant cardiac myocyte disease that causes left ventricle walls to thicken, which then affects the contractility of the heart, which causes various issues such as cardiac output, ischemia, arrhythmias, autonomic dysfunction, and mitral valve regurgitation. It can be caused by the presence of mutations in the sarcomere protein genes in the contractile muscles of the heart. This disease is the most common cause of the sudden cardiac death in individuals that are 35 years old and younger. These genes that are known to have the mutation are the beta-myosin heavy chain 7 and the myosin binding protein. In regards to splenomegaly, it is the enlargement of the spleen that could be caused by liver disease, hematologic malignancies, venous thrombosis, splenic congestion, cytopenias, splenic sequestration, acute or chronic infection of connective tissue diseases, infiltration disorders, or focal lesions. With liver diseases, there's an increased venous pressure, which causes the enlargement. And with acute infections, there's an enlargement due to the increased production of certain cells. In regards to the subjective information that we obtained, some red flags could be a previous MI or hypertension. Some things that we included in these red flags could also be risk factors such as diabetes, anemia, and history of smoking. The patient's goals for acute therapy is to address his chief complaint of wanting to be able to ambulate independently and return home as soon as possible. The patient reported that he was completely independent with his ADLs and ambulation prior, with no reports of any falls in the past year. He lives at home with his brother, where he has 3 stairs to enter into his home with a ramp on both sides. This patient will most likely receive inpatient therapy for 1 week prior to discharge, and then he can continue therapy either in an outpatient setting or home health. In regards to continuum of care and insurance coverage, insurance will not influence what type of treatment or the duration while he's in acute care. Insurance will be further considered for discharge planning, and a case manager would work with insurance and the patient to create a discharge plan.
So for balance tests and measures for static sitting, he was able to maintain balance without upper extremity use. For dynamic sitting, he was able to maintain balance turning left to right without upper extremity use. For static standing, he was able to maintain balance with handheld support. And then for dynamic standing, he was able to maintain balance with min assist while reaching. For his tests and measures for transfers, while moving from supine to sit, he was a max assist +1 for safety with the head of bed elevated 45 degrees. He was independent with maneuvering lower extremities off of edge of bed. He was max assist for trunk elevation and positioning at the edge of bed. He required verbal cues to maintain sternal precautions. And regarding his vital signs, it took 10 minutes for his BP to acclimate to the position change. While moving from sit to stand, he was min assist +1 for safety. He needed assistance to obtain full hip extension, and he had poor anterior tibial progression due to impaired balance and strength, which we see the balance measures in the slide before. And then while moving from stand to sit, he needed minimal assistance for control of descent +1 for safety, but he did need maximum assist to scoot back into the chair. For the patient's tests and measures for ambulation, it was monitored ambulation. He ambulated 40 feet without the use of an assistive device. There were 2 CTs to his H2O seal and 2 liters per minute per nasal cannula. He was a min assist +1 for safety with a close chair follow, and he exhibited decreased step length, decreased cadence with step 2 gait pattern, decreased single limb stance time due to impaired balance, and flat foot at initial contact.
Now we are going to take a look at some vital signs. During rest prior to any exercise, his heart rate was 87, blood pressure was 152/70, and respiratory rate was 20. His O2 stats were at 89 on 2 liters of oxygen via nasal cannula. He reported 12 out of 10 pain between his scapula as well. Prior to any exercise, they did a 1, 3, and 5-minute vital sign assessment at the edge of bed. His blood pressure at 1 minute was 163/67. His O2 stats dropped a little bit to 86%. At 3 minutes, his blood pressure was 179/61, and his O2 stats were at 90%. They upped the liters of oxygen to 3, and at 5 minutes, his blood pressure was 181/70, and his O2 stats dropped back down to 89% on 3 liters of oxygen. During exercise, his heart rate jumped to 100, his respiratory rate increased to 23, and his O2 stats were 90% on 3 liters of oxygen. He only reported a 9 out of 10 pain with decreased pain in his back, and his RPE was reported at somewhat hard. Immediately post-exercise and sitting, his heart rate dropped back down a little bit to 95 beats per minute. His blood pressure was 164/63, and his oxygen sats were at 91% on 3 liters of oxygen. His vitals were taken again at rest post-exercise, and his heart rate was 88 beats per minute. His blood pressure was 150/70. His respiratory rate was 20. His O2 stats were 96 on 4 liters of oxygen. His blood pressure pre-exercise was a little elevated, but the patient does not have a history of hypertension. His blood pressure continued to rise while sitting edge of bed, and no blood pressure was taken during gait. His blood pressure normalized once seated again during the rest post-exercise. His respiratory rate remained fairly high and got a little higher during exercise, which is to be expected. His heart rate response was normal during exercise, and patient demonstrated normal heart rate recovery. Patient demonstrated a slightly elevated heart rate, but that's fairly normal considering his surgery. His blood pressure was also high initially due to his history of hypertension. This could also be due to a recent surgery. There was some concern as to why sitting edge of bed increased patient's blood pressure so extensively. However, we may be able to contribute that to an inadequate dose of blood pressure medication to combat the symptoms that he is experiencing. The patient's respiratory rate was high and breath sounds were diminished in bilateral lower lobes, likely due to a history of smoking and inability to take deep breaths after surgery. Patient also required increased supplemental oxygen during activity and recovery. As far as other systems goes, neurologically he had impaired balance. This could be due to his anemia, lack of blood flow, hypertension, or his diabetes. In tegumentary, he has a sternal incision and presents with hairless distal bilateral lower extremity. These are signs consistent with PAD. As far as musculoskeletal goes, he has impaired upper extremity and lower extremity range of motion. He also has impaired gross upper extremity and lower extremity strength. All muscle groups were at least a 3 out of 5 bilaterally. We can contribute his upper extremity strength impairment due to his internal incision and precautions. His impaired lower extremity strength may be due to suspected PAD or general deconditioning. Patient has good communication and cognitively is AO times 3. He is calm and has a normal appearance. Here's our developed problem list for this patient and list of priority. Our main concern for this patient was that of safety. The things that we wanted to pay most attention to and that we deemed high risk are as follows. Patient is following precautions. He is a fall risk due to his balance impairments and continue monitoring his vital signs, specifically blood pressure. Other problems to be addressed are his ability to transfer from supine to sit, transfer from sit to stand, and stand to sit, his ambulation ability to navigate stairs, and ascend and descend safely properly. We also would like to address his impaired upper extremity and lower extremity strengthening. We'd also want to educate on things regarding his health like smoking, hypertension, diabetes, pain relief, and signs and symptoms to watch out for regarding PAD.
So for this patient, his plan would be to see him 3 to 5 times a week with 20 to 30 minutes total treatment time each day. We would address functional deficits, including sit-to-stands, ambulation, transfers and stairs with repetition and progression of exercises targeting these functional limitations. And we would address each of those in regards to our problem list and which would help him transfer safely and be discharged safely as well. His prognosis is he will likely be discharged to an outpatient cardiac rehab to continue working on any functional limitations, impaired lower extremity and upper extremity strength, and improving cardiopulmonary endurance. And he's expected to have a fair prognosis due to pre-existing comorbidities.
Now looking at what professionals we want to refer to. So we want to refer to occupational therapy. This would be good for our patient to help assist with ADLs, dressing, toileting, feeding, and grooming. Also, we want to refer to respiratory therapy to help assist in proper breathing mechanics. We also want to refer to the physician regarding dosage of hypertension medication and PAD signs. Now looking at our goals for physical therapy, our first long-term goal is in 1 week, patient will be able to ambulate 500 feet with supervision and appropriate vital signs in order for patient to be able to ambulate in the home. Our short-term goal to go along with that is in 3 days, patient will be able to reach outside of their base of support 5 times with supervision and no loss of balance in order to improve dynamic standing balance. Our next long-term goal is in 1 week, patient will be able to transfer supine to and from sit with head of bed 30 degrees elevated, min assist with minimal verbal cues in order to improve bed mobility. Our short-term goal to go along with that is in 3 days, patient will be able to roll right and left with supervision while maintaining precautions with minimal verbal cues in order to improve bed mobility. Our last long-term goal is in 1 week, patient will be able to ascend and descend 3 stairs with reciprocal gait pattern without handrail with supervision in order for patient to enter and exit the home. Our short-term goal to go along with that is in 3 days, patient will be able to perform 5 standing toe touches on each leg onto an 8-inch platform with supervision in order to work towards patient being able to enter and exit the home.
Going into the treatment plan, we want to be very cautious of the biggest 3 things on our problem list, which are the fall risk, no. Looking at the treatment plan, there's going to be this disclaimer that all interventions will be completed while maintaining precautions, educating on fall risk, and maintaining appropriate vital signs. So going straight into the education, we need to explain to them their precautions. We need them to understand their precautions and abide by it even when we're not there to remind them. And their precautions are moving the tube, and we want to say you can move your arms, but it's limited. A lot of hospitals have a handout, which I think is very, very beneficial for a patient to help them remember when we're not around. And so we want to let them have that and also have it in a place that they can easily see it to always be reminded. We want to explain that our patient, you are a fall risk. The reason why is you've had a major surgery, you have limited upper arm use, and so with that, we want to explain to them how whenever you get up in this acute phase, you always want to have someone with you. You don't want to just get up and start walking around, and this is going to be very vital at night. Whenever they wake up and if they have to go to the bathroom, we want to make sure that they understand how they can move around safely. This also means that we also need to let them have their call light within reach, so if they do need something, they can press that. With our vital signs, we want to be aware of the Borg RPE scale and that moderate range for exercise, which is 11 to 13. Obviously, all vital signs will be monitored: blood pressure, heart rate, oxygen, all of that will be monitored, but we want to explain to the patient we're looking for that RPE of the 11 to 13 range so that it's moderate, which is appropriate dosing for this patient. Another thing just to educate is pressure reliefs to prevent wounds. That'll be important for the patient, and the nursing staff will also help us with that. Moving on to the next stage of our treatment plan, we want to work on transfers and their strength. Strength overall will come back in time, and it'll be more for the cardiac rehab and outpatient to fully focus on strength. But while we're in the acute care setting, the biggest thing we're focusing on is functional strength, so those transfers. So to practice and to increase the strength for supine to sitting edge of bed, we want to practice rolling left and right while maintaining those precautions, because remember, those are the most important thing to kind of keep in mind with these patients. And then we want to practice going from side lying to edge of bed. How we're going to practice this is we're going to have the head of bed elevated, so that's less work on the patient, so they understand the mechanics while maintaining their precautions while they're doing this. And then as we slowly lower the head of bed down, that'll help increase the patient's functional strength. Next, going from sit to stand. With a lot of things in physical therapy, it does multiple things. This is going to help us on our transfers, but this also is going to be a lower extremity strengthening exercise. And so, similarly to the supine to sitting edge of bed, with the head of bed elevated to make it easier, we want to elevate the bed entirely, so that means that the patient is almost in a semi-stand, getting up to a full erect position. Over time, we want to decrease this, and over the course of the session, we're going to decrease this so that more muscle engagement is occurring. And then another thing that we can do, if the patient is needing some more reinforcement with the legs, or if they are not able to stand right away to kind of get that neuromuscular recruitment, we could do resisted knee extension and flexion. This is also just going to help us strengthen the lower extremity. For most of the upper extremity strengthening, for us, it's really just maintaining the precautions and explaining them. They can move their arms, but it's very limited. That's going to be more for cardiac rehab to address. The final area of our treatment plan is gait and balance. This is really important and crucial for the patient when they go home or they go to the next place. Our patient has steps to enter the home, so we need to do stair training. To start, you will see that we did stair taps, and that's our demonstration. And this is onto an 8-inch surface, which is about the height of a step. And this is going to help with balance, shifting that weight side to side, as well as preparing for stair training. Eventually, we want to practice stair training with reciprocal stepping pattern. With this, we don't want the patient to pull up with the rail, so we will have to make sure we note that and explain that to our patient. Another thing we do want to do is gait training. We want to work on a step through gait pattern, not just stepping up to a step 2 gait pattern. We want to step through. And we do want to strengthen the dorsiflexors to improve that initial contact, because in our patient that's lacking. Finally, we want to do postural control and balance. So to really focus in on this, of course, all the things that we have done with them, it's going to help them with their posture control and balance. But to specifically hone in on that, we want to do stepping forward and backwards and side to side. This is going to get multi-directional movement that's going to really challenge balance and postural control. And so that's why we want to implement it into our treatment plan. All right, Dr. Fick, we were very excited to make this chart for you. This is just to help explain how our brains were thinking whenever we were going through our problem list and coming up with interventions. The reason why there's not a long-term and short-term goal for everything on the problem list is just because the rubric didn't require it. Obviously, if we were in the clinical setting, we'd have a goal, short-term and long-term goal for all of this. Nothing on this page is new. It's all in the presentation previously, but it is written out in a different way so that you can see how we were thinking and how we addressed each one of the items on our problem list. I'm not going to read through everything because I have explained prior all of the things on this chart, but this is just so that you can see how our brains connected everything on our problem list to an intervention.
When looking into the literature on hypertrophic cardiomyopathy, most of it was structured around the benefits of using moderate intensity exercise for people with this diagnosis. So the one article that I wanted to go through was Redefining Management in Hypertrophic Cardiomyopathy, the Role and Challenges of Exercise Rehabilitation, published by Verma et al. In 2024. It is a narrative review with systematic elements, and it summarizes current evidence on exercise prescription in patients with HCM. It looked over 6 different studies and condensed the information to draw the key takeaways from each. It found that moderate intensity exercise, as measured by METs of 3 to 6, 50 to 70% max heart rate, or 13 to 14 on the Borg scale, was the best for these patients. This was pretty groundbreaking since it goes against prior evidence that suggested light exercise, if any at all from some sources, should be prescribed due to concerns of sudden cardiac death due to the risks of HCM, such as disrupted coronary blood flow. It emphasized the need for a warm up and cool down for these patients since there is some cardiac issues, which is what we've learned in school. One of the included studies done by Sabiri et al. That I found was the most well done and well presented showed a statistically significant increase in VO2 max through moderate intensity exercise program. It was a randomized controlled trial of a pretty decent amount of people, and it showed pretty much what the whole article had been saying, that moderate intensity exercise, when measured by clinicians and therapists who knew what they were doing, was beneficial. However, in this literature review, there was no meta-analytic statistics ran by the authors to compare the studies in the narrative review. So it was more so just describing them and doing descriptives rather than drawing their own conclusions from the data presented. Continuing our literature review, some strengths of this article was that it included several randomized controlled trials and prospective studies in its summarization of the current clinical evidence. It highlighted 6 studies in specific and showed the statistics that were presented with those. It emphasized the need for patient-centered approach, stating that there needed to be physician involvement as well as those who know what to do when vital signs drop to inappropriate ranges. Some weaknesses of this study were that it was more narrative in nature rather than systematic. There was a variety of exercise protocols listed, so it limits the comparability of these studies to each other. Many of the studies are from cardiac rehab facilities rather than, say, an outpatient physical therapy or from an acute care setting, and there's limited long-term follow-up. Using our clinical judgment off this narrative review, as well as other articles that I saw that reiterated this information, moderate intensity exercise should be implemented during exercise training. As physical therapists, we are movement experts, and we understand how vitals should respond to treatment, as well as understanding how comorbidities, such as those our patient has, will affect a patient's individualized exercise prescription. There really weren't many articles or any that I could find on specific interventions like you see with patients with a stroke or patients with Parkinson's, such as, using NMES on muscles or doing the large amplitude movements. Pretty much all that I saw were similar to this literature, this article, just stating the importance of moderate intensity exercise in order to reap the most benefits possible for the patient.
The treatment we decided to demonstrate is the step tapping, which will help our patient prepare for stairs when they return home. The first things first is we always want to make sure we take vital signs before and after the treatment session to ensure that they are appropriate, and we will also be monitoring them throughout the session. After vital signs are taken, the physical therapist will prepare to demonstrate and explain the exercise to the patient. This does include explaining the patient's precautions and how to maintain them. Biggest ones for our patient are going to be the sternal precautions and the limited use of the upper extremity. After everything has been explained and vital signs are taken, then the physical therapist will prepare to ensure that the environment is safe. This includes putting on a gait belt and removing any equipment and organizing the lines in a way that will keep the patient safe, as well as the physical therapist throughout the treatment. With the gait belt, you do want to be cautious with anyone who has a sternal incision or any chest tubes, that they're not interrupting any or putting pressure on those incision sites. Since our patient is like a day or two post-op, we're assuming that the chest tubes are taken out, and we also are ensuring that the gait belt is below the incision. Once all of that's done, now we can perform the exercise. So the physical therapist is going to assist the patient with the sit to stands and help maintain balance throughout the treatment to ensure the patient's safety. We want to make sure we get to a moderate level of intensity for the treatment to be effective. After the treatment, we want to take vital signs again to ensure everything is okay. And like I said before, throughout the treatment, we will be monitoring their vital signs and their symptoms. Finally, once we get the patient back into a safe position for us, we do have a bed in this video, but we're assuming they're in a chair, or if they were in a bed, we would get them back safely into the bed and not leave them at the edge of the bed. We also want to make sure their call light is within reach, and so for this video, we handed it to our patient. Thank you.